Welcome to Introduction to Clinical Practice, lecture on ethical standards in healthcare. The purpose of this module is to provide updated and relevant information on ethical standards in healthcare. You are encouraged to seek other sources and use the references at the end of this module. The objectives for this session include the ability to define ethical behavior, to describe the healthcare provider's role in informed consent and advance directives, and to be able to describe the different types of advance directives. The term ethics encompasses many facets. In particular, healthcare ethics is concerned with the rights, responsibilities, and obligations of healthcare professionals, care institutions, and clients as well. To behave ethically is to conform to accepted standards of conduct. Most professions within the healthcare arena actually describe a particular code of ethics for their profession. We encourage you to contact or search through your professional organization to find the particular code of ethics that will pertain to your discipline. In the following slides, we will discuss the history, process, and importance of informed consent. In 1906, in the United States, an act named the Federal Food and Drugs Act of 1906, or the Wiley Act, was passed. Prior to this, there were no regulations regarding ethical use of human subjects in research. There were also no consumer regulations, no Food and Drug Administration, no common rule, and no institutional review board. Since then, the international and U.S. medical communities have taken numerous steps to protect people who take part in clinical research. Let's look at some key events which have contributed. December 9, 1946, marked the beginning of the Nuremberg trials. Led by an international tribunal planned and implemented by the United Nations War Crimes Commission, the intent was to detect, apprehend, try, and punish people accused of war crimes during World War II. A particular section was devoted to crimes against humanity, which were described as, namely, murder, extermination, enslavement, deportation, persecution, and other inhumane acts committed against any civilian population. What was important was that they were considered criminal acts whether or not they were in violation of the domestic law of the country were perpetrated. In other words, prosecution fell within the province of international law and went beyond the particular political climate of an individual nation. The crimes of concern during the Nuremberg trials were the plan to exterminate the Jewish race and the medical experiments conducted by the Nazis. German physicians were charged with conducting medical experiments on thousands of concentration camp prisoners without their consent. Most of the subjects of these experiments died or were permanently crippled as a result. In the box to the right, you can see some of the various named experiments. We will review a few to help us follow the particular rights violated. Two prominent physicians sought convenient means of mass sterilization that would enable the Third Reich to carry out the biological destruction of conquered nations by removing reproductive capacity. One developed a method of non-surgical mass sterilization. A specially prepared chemical irritant that produced severe inflammation was injected into the female reproductive organs of several hundred Jewish women from various countries. Within several weeks, the fallopian tubes grew shut and were blocked. Frequent complications included peritonitis, hemorrhage, fever, and sepsis. Multiple organ failure and death frequently followed. Others were put to death so that autopsies could be performed. In a second study, the ovaries and testes of female and male subjects were exposed to X-rays at various intensities and intervals to determine the optimal dose of radiation. This resulted in severe burns and lesions that wouldn't heal on the abdomen, groin, and buttocks. Many subjects died from complications. Some were subsequently sent to the gas chambers, and others had their testicles or ovaries removed surgically for laboratory examination. Of note, the results of the X-ray sterilization experiments were deemed unsatisfactory. Dr. Joseph Mengele held a PhD and a medical doctorate. In close collaboration with the Kaiser Wilhelm Institute for Anthropology, Genetics, and Eugenics, he studied the phenomena of twins, the physiology and pathology of dwarfism, and specific cheek cancer found in gypsy children. Mengele subjected his patients, many of whom were children, to painful and exhausting medical examinations. After exam, the subjects were killed by phenol injection so that their internal organs could be analyzed. From 1941 to 1944, clinical trials of the tolerance and efficacy of new medications were performed on Auschwitz concentration camp prisoners. This work was commissioned in part by none other than the Bayer firm. Prisoners suffering from contagious diseases and those who were deliberately infected were forced to take substances which caused painful bloody diarrhea, vomiting, and circulatory impairment. The Nazi physicians were declared guilty of crimes against humanity in performing experiments on human beings who were not volunteers and did not consent. These acts, as well as their participation in the extermination programs, displayed a clear violation of medical ethics. As a direct result of the trials, the Nuremberg Code was established and adopted by the United Nations General Assembly in 1948. The Code was the first major international document to provide guidelines on research ethics. Major points were that the voluntary consent of the human subject is absolutely essential, and that the benefits of research must outweigh the risks. The concept of voluntary included that participants are able to consent, they are free from coercion, and that they comprehend the risks and benefits involved. That is, they have the understanding and knowledge of the subject matter needed in order to make a decision. Information supplied must include nature, duration, and purpose of the experiment, the method and means by which it is to be conducted, and all possible effects as a result of participation in the experiment. The responsibility for the quality of the consent rests upon each individual who initiates, directs, or engages in the experiment. Researchers are further responsible to minimize risk and harm and to be sure that the experiment is expected to yield fruitful results for the good of society. Patients must be free to withdraw at any time, and possibly most importantly, the scientist in charge must be prepared to terminate the experiment at any stage if there is probable cause to believe that a continuation of the experiment is likely to result in injury, disability, or death to the experimental subject. On July 25, 1972, Jean Heller of the Associated Press broke the story that there had been a 40-year non-therapeutic experiment called A Study on the effects of untreated syphilis on black men in the rural South. What was this? How did it happen? And how did it shape the ethical climate of our country? The study was named Tuskegee Study of Untreated Syphilis in the Negro Male, also known simply as the Tuskegee Study. It took place in Macon County, Alabama, on the campus of the Tuskegee Institute and was started in 1932. It was supported by the U.S. Public Health Service. The intent of the study was to record the natural history of syphilis in blacks. Much funding had been cut for health care in poorer areas, and it was felt that studying the ravages of untreated disease may highlight a need and help gain support for better health care. What started with good intent ended in disaster. A total of 600 men were enrolled in the study. 399 who had syphilis were part of the experimental group, and 201 served as control subjects. Most of the men were poor and illiterate sharecroppers from the country and did not know or understand the implications of their disease. When the study was initiated, there were no proven treatments for syphilis. The only possible treatment available was mercury and bismuth, which had at best a 30% effectiveness and caused debilitating side effects. Researchers told the men participating in the study that they would be treated for bad blood. This term was used locally to describe ailments that could include anemia, fatigue, and syphilis. In return for enrollment, the men were promised medical exams, rides to and from the clinics, meals on exam days, and free treatment for minor ailments. Also, there would be provisions for burial after their death. In 1936, a report was published, and it was decided that the information obtained was valuable enough to follow these men until death, when autopsy could further illustrate the ravages of tertiary syphilis, which included tumors, heart disease, paralysis, blindness, insanity, and death. Local physicians were discouraged from initiating any treatment so that the disease could be observed in its natural course. In 1947, penicillin became the standard treatment for syphilis. The men in the study were not offered this treatment. Up to this point, although the consent process was not optimal and no treatment had been offered, there really was no proven effective cure for syphilis. If you remember from the prior discussion of the Nuremberg Code, the researcher is required to stop a study if participation or continued participation in the study may be detrimental to the subjects. Over the years, nurses, doctors, and public health officials were either ignorant to or ignored the progress and repercussions of participation in this study. From 1947 through 1962, 127 black medical students rotated through the Tuskegee Syphilis Study Unit, but the fate of the subjects remained unreported. In 1968, Peter Buxton, an internal employee of the Public Health Service, raised concern about the ethics of the Tuskegee Syphilis Study. This concern was immediately shut down. In 1969, the CDC actually reaffirmed the need for the study with the support of the local American Medical Association. After the news story broke in July 1972 and exposed the study to the public, a panel was formed, and in October 1972 they reached the following conclusions. Although the men participated in the study freely, agreeing to the examinations and treatments, scientific research protocol was not applied, the men were never offered informed consent, and they concluded further that the study was ethically unjustified. The study was ended 1 month later. In 1974, a $10 million out-of-court settlement was reached to provide lifetime medical benefits and burial services to all living participants. In 1975, wives, widows, and offspring were added to the program. Due to the publicity, the National Research Act of 1974 was passed, and a commission was formed which was charged with identifying basic ethical principles that should underlie the conduct of biomedical and behavioral research, and to identify and develop guidelines which should be followed to assure that this research is conducted in accordance with the principles. What resulted was the Belmont Report in 1979. The report set forth 3 major principles. One was respect for persons, recognizing the autonomy and dignity of individuals. 2 was beneficence, an obligation to protect persons from harm. And justice, which referred to the fair distribution of the benefits and burdens of research. These principles underlie what we now know as the basis for informed consent. The goal of the informed consent process is to provide people with enough information so that they can make informed choices about whether to begin or continue participation in clinical research and whether to undergo surgical procedures. As a healthcare provider, you need to be aware of the different types of consents your patients may be required to sign. There are surgical consents, consents specific to anesthesia, blood products, and other special consents. For instance, any type of experimental research requires a very specific consent form, and this will be guided by the Institutional Review Board. If the patient is to be photographed, there needs to be a separate consent for that as well. Sterilization and termination of pregnancy have specific items within that consent that differ from a regular surgical consent. And if there's going to be the presence of a company representative in the OR, such as for a cardiac device procedure or an orthopedic procedure, where the representative may come in and scrub into the OR to give guidance on the equipment, there needs to be a consent. The patient needs to be aware that that person will be in the OR, and it must be included on the form. When you get back to your site, check to see specific consent forms that exist and where you can find them, so that when the questions arise, you are able to answer your patients in the best way. When initiating a consent form, be aware that you may not use abbreviations. Also, no acronyms may be used. For instance, if somebody is going for open heart surgery, the procedure must be written out as coronary artery bypass graft surgery and not CABG. Use language that's understandable to the patient, and remember that any changes to a consent will require a new consent form with new signatures. So, who can sign a consent form? An adult patient is considered any person who is 18 years or older, or if under 18 years old, if the person is married, is a parent, or is a legally emancipated minor. Let's look at which individuals under 18 years old do not require parental consent. A minor, who is an individual under 18 years old who is seeking sex-related medical care such as contraception, abortion, or prenatal care, does not require parental consent. It is felt, and it has been shown, that if parental consent is required, many of these individuals would not seek care, which would be far more damaging. An emancipated minor is an individual under 18 years old and could be living apart from their parents, self-supporting, and one who generally controls his or her own life. Understand that legal documentation is needed. The actual consent for surgery takes place when the responsible practitioner, that is, the person who will be performing the procedure, or an individual who is appropriately credentialed to perform the procedure and who understands the risks, benefits, and alternatives of the proposed treatment or procedure, and the patient agree to proceed. This physician or practitioner is responsible for explaining the procedure, the risks, benefits, and alternatives, and the potential use of blood and/or blood products that may occur. This is explained to the patient and the designated family or support people as indicated. The informed consent is this discussion, not just the piece of paper. The patient must sign his or her own consent unless there's documentation that the person is mentally incompetent. You can see in this excerpt from an actual consent form that all the items are included in the medical staff certification. Take a moment to review. In all our interactions with patients, and especially during the process of consent, we need to take into consideration the health literacy level of our patients. This is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. It's not dependent on the educational level of the person. An individual may be highly knowledgeable and skilled in a certain field or an area of expertise, yet not understand the jargon, the language, or the concepts involved in healthcare. Therefore, consent language must be tailored to an individual, and consent items must be explained in terms that the patient can understand. Consider the concepts that follow. Retention of information is fleeting, especially when somebody is in a stressful situation. Sometimes the person will not be listening as carefully or processing in the way they normally would. They're therefore more dependent on the integrity of the healthcare professional to present the information clearly. Involving others may also help the patient. Having a significant other or chosen person with them, this person may be able to better focus, remember, and retain the information so that it can later be discussed with the patient. Our obligation to our patients is to always keep these concepts in mind and make sure that we deliver the information in a way that can be useful to our patients. How about consents in times of emergency? A true emergency is defined if not to proceed immediately may result in the loss of life or limb or vital organ. This means that if a patient comes into the emergency room and is not conscious and is not capable of signing a consent, and you're not able to find a healthcare proxy or next of kin who can provide the same consent, if the procedure needs to be done to save somebody's life, somebody's limb or organ function, then we have the obligation and the legal right to proceed with the procedure. When a signature can't be obtained, surgery can proceed without this consent. The surgeon must document the situation and also make every attempt during the procedure or after to obtain the consent from the appropriate person. Here are some other items to consider. Consents do expire. Depending on the type of procedure or the particular site, consent might range from 30 to 60 days from the date that the consent was signed. You'll need to check your own policy for various types of consents. Something to remember is not to obtain consent after the patient has received mind-altering medication. Understanding that errors may happen, one will need to make the decision as to whether the procedure will have to be delayed until the patient can actually sign the consent. If it's an emergency procedure, it may have to go ahead as discussed prior, or the practitioner may need to find a healthcare proxy or next of kin who can sign the consent. Do not have the patient sign the consent. Understand everything's documented, and you would not want to have to see that show up in a chart that the patient signed consent after having received a mind-altering drug. You can take telephone consents if there's no way possible to do it in person. You need 2 witnesses with a double signature, but before you proceed, check your site policy. And as discussed before, anybody who's involved in a research study or therapy needs to have a specialized consent that has been approved by the IRB. If the patient's primary language is not English, you will need to use some type of medical interpretation services that is approved by the North Shore LIJ Health System in order to deliver any type of consent. You may use a language phone. The type might differ, the company might differ, so check with your site as to what type you're using and where you should obtain that. You can use a North Shore LIJ Health System approved interpreter. Please note that although an employee may be bilingual and feel that they speak both languages equally, an employee may not serve as an interpreter unless that person has been credentialed by the North Shore LIJ Health System as a bona fide interpreter. There are interpretation services for the hearing impaired. There are sign language interpreters who will come to the hospital and interpret in person, or there are also video remote interpreting services that can be obtained. Know what type of resources you have on site. So, what are our take-home points about the process of consent? Always remember that you have a moral and ethical obligation to ensure that patients don't feel forced or pressured into any treatment. You need to always make sure that the patient receives accurate information about what will be done. Providers must ensure that patients understand this information, and patients need to understand that the consent can be withdrawn at any time. We will next review the different types of advance directives and the role of the healthcare provider. Advanced directives are instructions given by an individual specifying what actions should be taken regarding health or life-promoting activities in the event that he or she is unable to make decisions due to illness or incapacity. Continual advances in technology have made it possible for life to be maintained through countless medical conditions and situations. With this achievement also comes the dilemma of potentially prolonging physical existence without improving actual quality of life. We see this impact in several ways. Use of sophisticated interventions are costly, especially when utilized over a long period of time. The emotional drain on the patient may outweigh the benefit of longer life, especially if the person cannot communicate his or her desires or needs. The family may agonize or argue over what the patient would have truly wanted. Exploring individual wishes and discussion about options well before the onset of illness is actually the best time to begin this process. In October 2012, a 28-year-old terminally ill woman named Grace Sung Eun Lee expressed the desire to be taken off life support. An inoperable brain tumor had left her paralyzed from the neck down. She was dependent on a ventilator and tube feeding for nutrition. But her devoutly religious parents viewed this decision as suicide, believing that this decision would be the work of Satan and that she wouldn't go to heaven. Stating that she wasn't competent, they filed a court order to block doctors from following her request. The court, however, ruled that Lee was capable of making her own end-of-life decisions. Once she had the capability to make her own decision, however, she did not act immediately. Ultimately, she honored her parents' wishes and went home on ventilator support to live out her last weeks. Use this case to reflect and consider some of the following questions. What are some of the issues or gray areas of ethical decision-making highlighted by the story? How do family dynamics play a role in healthcare decisions? Is there always a clear-cut right or wrong? What types of cases have you referred to medical ethics staff? We will now review the different types of advance directives you may encounter. Note that the medical doctor or delegate is responsible for obtaining these advance directives. Healthcare proxy is a term that is familiar to most of us. A healthcare proxy is an instrument, or actually the document, that allows an individual to appoint an adult healthcare agent to make healthcare decisions in the event that such individual is incapable of executing such decisions. It is a legal document in accordance with New York State law. Note here a sample of a typical healthcare proxy form. You should encourage your patients to fill out these forms or make these considerations well before they encounter an illness or an emergency. And certainly, when they appoint an agent, there should be a conversation with that agent so that person knows what the individual would want if they were not able to make their own decisions. Some people may have constructed what is known as a living will. This is basically a written statement detailing a person's very specific desires regarding medical treatment, again in circumstances where this person is no longer able to express informed consent. It can include instructions on use of dialysis, ventilator machines, methods of resuscitation. Do they want to have tube feeding? Would they want to be an organ or tissue donor? And particular types of life-saving medicines. This is a helpful document for the person who's been appointed the healthcare agent if they need some guidance as to what the individual may have wanted. However, it must be noted that this is not a legal document in New York State. There's no standard form for living will in New York that is interpreted in a uniform way. The MOLST form, which stands for Medical Orders for Life-Sustaining Treatment, is a legal document in New York State. However, its use is limited to those who may reside in a long-term care facility requiring long-term care services and most likely is terminally ill and may die within the next year. This is, again, specifies which treatments the person would like to either avoid or receive regarding life-sustaining treatments. Many states have a similar form. The one in New York State is called the MOLST form. It is a legal document. It must be signed by a medical doctor. It's portable. The patient will take the form with them. It can be used as a DNR order, and it specifies, again, how aggressive the plan of care is to be. Examples: do they want to be on a ventilator? What type of nutrition would they want? Would they want IV therapy, and what type? It is recommended for any patient who's in long-term care, in a skilled nursing facility, or in a hospice situation, or receiving palliative care. When a do not resuscitate, known as a DNR order, is placed in a person's medical record by a doctor, this informs the medical staff not to initiate cardiopulmonary resuscitation. That is, no chest compressions, no ventilation, in the event of a cardiac or respiratory arrest. This does not mean that the patient is not treated otherwise. The patient may receive antibiotics, transfusions, dialysis, and other life-sustaining medications and treatments. If your patient has an order for do not intubate or DNI, check your site policies carefully to understand exactly what this entails. Generally speaking, intubation refers to the process of placing an endotracheal tube into the lungs to provide ventilation. Patients, however, may accept cardiac compressions and an ambu bag to ventilate the lungs without the actual placement of the tube. Therefore, you must be very clear as to the patient's exact wishes and encourage the patient, when making these decisions, to clearly delineate what he or she would want done. If a patient has an order for DNR in place and needs to undergo a surgical or other procedure requiring anesthesia, there must be a clarification of the DNR order with the associated form completed. This is to be obtained by the patient's physician. Contrary to what some believe, the consent for surgery does not automatically revoke a DNR order. There may be circumstances where the patient maintains his or her DNR status during the procedure, such as minor surgeries under local anesthesia. Certainly, if a patient undergoes a surgical procedure which requires intubation and cardiopulmonary bypass, such as an open heart surgery, that is not a possibility. However, in all cases, the clarification must be discussed with the patient or patient proxy, and the decision must be documented. Note that the physician is not required to compromise his or her ethical beliefs if not comfortable performing a procedure without resuscitative ability. If you've ever been haunted by the term "rules are made to be broken," you will find no exception related to advance directives. Know that advance directives may be revoked at any time. Revisions can also be made at any time. Proxies, family, and patients can rescind a DNR order. Sometimes this may even happen just at the time of cardiac arrest. Although we may believe we know best, we must honor the wishes expressed in the moment. If the family or patient acted rashly and wishes to terminate treatment later, modern procedures do allow for this. When a change is made in any advance directive, goals of care should be reviewed and revisited. This is an ongoing process. Know that DNR/DNI orders need to be renewed every 7 days, and that progress notes should be written weekly and when the condition changes. On the next few slides, you will find references pertaining to the information contained within this presentation. We encourage you to further explore those areas of particular interest or of particular relevance to your practice. And we thank you for reviewing this presentation with us today.